you may see a symbol that indicates that a recording is occurring. And thank you very much for allowing us to do that. And we will be posting the recording onto the ICCPR website. Today, just a reminder of our ICCPR, our job is to promote cardiac rehab and to ensure that when people think of cardiac rehab, that they think of it as a necessary part of cardiac patient care, rather than an opt-in, something that's nice to do. And tonight we'll be having presentations from people who are very committed to cardiac rehab and have some great ideas. We're very lucky because we have 4 speakers who are well known for being cardiac rehab experts. And they'll be providing us with this evidence, ideas, and techniques. But I'm just going to momentarily share with you some exciting news that we have from ICCPR for everybody. And excuse me while I just get onto the correct screen. So we're very pleased to announce that we have scholarships. ICCPR runs the Cardiovascular Rehabilitation Foundation certificate. It normally costs US $100, and it includes 8 modules, an 80 question multiple choice exam. It's a really good way to make an entry into cardiac rehab. We're very pleased to announce that the group that I work with in Australia has been very lucky to get a large grant. And what we would like to do is to support people from low and middle income countries to complete the rehab, our ICCPR Rehab Foundation certificate. So we have 20 scholarships for health professionals and trainees working in low and middle income countries. The application process is on the ICCPR website. Just to remind you, eligibility, you have to be a healthcare provider living in a low middle income country, practicing as a clinician, or intending to work in this section. Follow the selection criteria on the website. You have to be eligible. We'd like you to submit a little video or a short 100-word explanation of why you would benefit from doing the certificate. Applications open March 24. The deadline for submission is May 29, and the decision is June 23rd. So we're very pleased to share that good news. Today, we're going to have 4 speakers, and the first of those speakers is Professor Susan Dawkes. She's head of school, Professor of Nursing and Cardiovascular Health, School of Nursing, Midwifery and Paramedic Practice, and an honorary research consultant cardiology department, NHS Lothian, and president of the British Association for Cardiovascular Prevention and Rehabilitation. I forgot to say that that's at Robert Gordon University in Aberdeen, United Kingdom. It's our pleasure for Susan to begin talking to us now. I will mute now. If you would like to ask Susan a question or any speaker a question, could you please use the chat function throughout the 4 speakers' conversations? And then at the end, we'll have a live opportunity to ask questions. I will look at the chat after each speaker, ask them 1 or 2 questions, but we'll save the bulk of our questions for the end of the conversation. Thanks very much, Susan.
Thanks, Robin, and thanks to you and the ICCPR for inviting me to give this presentation. So just to share with you, this is a presentation that I gave at the Singapore Prevention and Cardiac Rehabilitation Symposium in October of last year. My interest is really around how can we support healthcare providers to be, in turn, supporting patients with their mental health. And I'm going to take you through a summary of the presentation that I gave in Singapore last year. If I could have the next slide, Gabriella, if that's okay. I have no conflict of interest to declare. The overview of the presentation then, so I'm just going to give you a broad context, which probably will come as no surprise in the middle of this pandemic. I'll go through how we identify psychological issues just to remind us of these things. Then I'll talk a bit about ways of supporting patients, not just for us to support patients as healthcare professionals, but actually how can patients support themselves with their own mental health and well-being. And then I'll finally finish with a notion around how do we actually support the preparation of healthcare professionals to do this, because it's not that easy. So in the World Health Organization's definition, I'm sure you all know this, but obviously being healthy is not just about not having a disease or a condition. It's about that state of complete physical, mental, and social well-being. And that's incredibly important. We often focus on the physical. The mental's more challenging in some cases, and the social is again something that's not always in our influence in many cases. So I just wanted to share that with you just so that we keep that in mind as we go through. The context then is that when I looked at the statistics that are currently being given in relation to mental health disorders or mental illness, you all know, I'm sure, that mental illness and mental health is a real challenge across the world. So, back in 2017, and you'll realize that this has now got significantly worse, but back in 2017, just under 800 million people across the world were living with a mental health condition. And that was just over 10% of our world population. Slightly more females than males. But in life, 1 in 3 of us will be affected at some point in time by a mental health condition, mood disorders, anxiety, whatever it may be. The pandemic has made things a lot worse. And I think we can probably all identify with that in our own respective countries. And you'll see there that during the COVID pandemic, the prevalence of depression is now at 28%, anxiety 27%. Then you get to psychological distress and it hits 50%. Now, this is not identical in every single country. It was very much dependent on the measures of lockdown that were imposed by the particular country government. And obviously different countries did things in different ways, but that's had a massive impact on people's psychological health. But it really is very impactful on their health. They don't live well with these conditions in many cases. So it causes 1 in 5 years live with a disability. And each week, as I say, 1 in 6 people are experiencing that mental health problem. So it's a vast problem that affects many people. And I'm sure you've cared for a lot of these people throughout your careers already. If I can have the next slide, Gabriella. So what about mental health and cardiovascular disease? So, our populations are they're not immune to mental health problems, for sure. In many cases, they actually are more significant. So we know that up to 30% of people who have cardiovascular disease will also have depression. Significant number have anxiety. And this is not just people feeling a bit low in mood or they're feeling slightly anxious. These are diagnosed conditions that are having a major impact on people's lives because they are prolonged in nature. But the issues are really that, firstly, that depression will cause, as you can see there, a 3 to 4-fold increase in mortality post-MI. If you have AF or heart failure, you're more likely to have anxiety or depression. And then we have good knowledge that people who experience depression are more likely to have cardiovascular disease and these major adverse cardiac events. So it looks as if there's a bit of a chicken and egg situation, if I may describe it like that. If I could have the next slide, Gabriella. So the connection between mental health and cardiovascular disease is there. Some of the evidence is not particularly strong, but what we think goes on then is this circular process, this what I would describe as chicken and egg, which one came first. So we know if you are feeling anxious or depressed, you will have a physiological response to that. So heart rate goes up, blood pressure goes up, the cortisol levels increase, and that will obviously in turn then make you more likely to have a cardiovascular event. We know, though, that also in addition to that, that people who are suffering from some sort of mental health condition may try to cope with that through behaviours that we wouldn't necessarily think are particularly healthy and would then predispose them to a greater risk of cardiovascular disease. So if they smoke tobacco, they're more likely to smoke more. They're more likely to have a high fat, high sugar diet, and they're less likely to take physical activity. So that again, in turn, will make them much more likely to have those cardiovascular factors. But the opposite is also true. So if you have some sort of cardiac event, you then obviously then will have seen patients who are affected by that. So people think, I've heard it myself, am I going to die? It's life's not worth living now because I've got heart failure. There's so much that is wrapped up in this around people's health and well-being. So real, cyclical process here that it's difficult to unpick the bits between them. But the thing I would probably draw your attention to on this slide just before I move on is that post-traumatic stress disorder is certainly something where the evidence is really emerging now. So people who do have cardiac events are now, there's reports coming through that they are suffering from what would be termed PTSD, but equally people who have PTSD are now much more likely to have cardiovascular disease. So again, it's certainly something that I think is worthy of much more investigation. If I can have the next slide, Gabriella, please. So what's the reaction to this? So you see there that reactions are, you can have people with anxiety, depression, fear, helplessness, the list is there for you to see. But what do the symptoms look like then? And I think probably these would come as no surprise to us. So that low mood, difficult to figure out, and particularly when you're having brief interventions with people, how do you actually, make sure that you are you're seeing something that's low mood and it's not just someone being a bit reluctant to share their thoughts and feelings with you. But I think there's a huge gradation in this of some people will just be feeling a bit low and a bit, unhappy that they've had some sort of cardiac event, feeling a bit sad that they've had this happen to them, all the way through to someone might now feel quite suicidal because of this. And that brings a huge challenge to us. I'm a nurse. I'm a general nurse. I'm not, a specialist in mental health, but equally, I now find myself in many cases trying to deal with people who have pretty significant mental health conditions. So I'm conscious of that as well, and I'll talk more about that in a little while. Next slide, please, Gabriella. So what can people do? So that, there's a lot of publicity at the moment in the United Kingdom, and a lot of the mental health charities in particular will really try and broach the subject. And we know that 75% of people who have a mental health condition are not likely to actually share that with anyone. They're really reluctant to seek any help. There's a slogan here from one of the mental health charities, which is, it's okay not to be okay. And I think that's certainly something that I'm seeing across the world now in a lot of the campaigns to try and encourage people to actually talk about this. So people can help themselves by firstly actually figuring out what is the cause of their mental health problem. Not everyone will be able to do that, but what stressors are the problematic ones? And then they can find ways to actually effectively manage those. That won't work for everyone though, for sure. They can try and get support from family and friends, but there is still a stigma attached to essentially sharing that you feel like you've got a mental health condition. They can set achievable goals. If I look at my workload, I have a list, massive list of things to do, and yeah, that can feel really overwhelming at times. But if you break it down into individual things, you get a sense of achievement then of, okay, I can tick things off my list. And actually, I feel now a sense of accomplishment. They shouldn't ignore these symptoms, though, particularly if they're prolonged in nature, and they should be encouraged to talk to a healthcare professional if they feel able to do that. But equally, they have to then have access to that healthcare professional to actually facilitate that conversation, which again can be problematic. Pandemic hasn't helped that. Much of the consultations in this country, and I'm sure across the world, are such that they're being done online like this and not face to face. And sometimes that then you miss the non-verbal cues that you would probably pick much more up if you were face to face. If we can have the next slide, Gabriella. So what do we do then? So if we have someone, in cardiac rehabilitation, we have comprehensive assessment of patients' rehabilitation needs. That should be individualized to make sure that the plan and the action plan that comes beyond that is individualized to the patient. But what about that psychosocial assessment? So the clinical guidelines are very clear that it should be comprehensive in nature. It should most certainly be patient-centered and holistic. So not just focusing on mental health, but looking at the broader picture of what does this do to the patient in terms of their health and well-being generally. We should be screening for psychological, psychosocial, sexual health and well-being. And really the assessment then encompasses these things here. So is a patient experiencing any sort of psychological distress? Indeed, do they have PTSD? What are the stressors? Is there any substance misuse then in there? And how does then all of this really impact on their quality of life? And I think we do that to some extent. If I can go on to the next slide, Gabriella. So as a minimum, what we in the United Kingdom through BACPR would suggest is included in that assessment is the list that's here before you. So, assessment of the person's mood. Are they distressed in any way? What's their emotional state? Now, I recall from some of the research that I did a few years ago when, I remember this lady vividly who had been called by the cardiac rehabilitation team. How was she? She said she was fine. I then saw her when I was doing my PhD, and she shared with me that she was a patient who had stable angina, but had a PCI essentially to help manage her symptoms. So, not particular cardiac event, just an intervention that she had, but she was terrified post-procedure and had little information about what to do, but she lay on her sofa for 6 weeks because she was terrified that if she moved, she would die. But she hadn't shared that with the rehabilitation team because they called her and hadn't had that face-to-face visit. But it's quite difficult if patients don't share with us what they're feeling. So what about their quality of life? What about their health beliefs? For her, it was she had misconceptions about her heart disease that was really impacting on her mental health and well-being. And that then impacted on her ability to engage with rehabilitation because she again felt that she wasn't in a place, she had a problem with her heart. How on earth could she go to rehabilitation and exercise? But of course, then she had no sense of it was broader than that. It's cardiac rehab's not just that focus on physical activity and exercise. There's a bit about unpicking people's adaptation to illness and particularly around mental health. And I think that's incredibly important, but it takes time to do. There's also real emphasis on what about the family relationships? What about their social support? How does all of that then really help to support the person or not? Because I think if you understand that, it really helps you understand what you're doing. And then the final thing is about that medication adherence. Next slide, Gabriella. So what do we aim to do then through our interventions? So the support's really to help people, and this is not dissimilar to what we do in rehabilitation. It's of course just inherent in what we do, but helping people to understand what cardiovascular disease is and how they can actually self-manage that. What about the psychological factors and how do they then influence their recovery? So for this lady, major impact on her recovery, which should have been relatively straightforward. Her angina symptoms had, much reduced in the frequency, but she really had this mental health condition now, which was very prolonged in nature, which was having a significant impact on her life. How was she coping with that? Well, she didn't smoke, but actually she wasn't taking any exercise at all because she hadn't really moved from the sofa in many weeks, but she was eating much more. So her weight had gone up. So it wasn't a particularly effective coping strategy for her. So really then the whole point of this is help people set these realistic goals, which I think we do anyway in rehabilitation, try and address any misconceptions and help people work through this. Think about that meaningful participation in all aspects of life. And that's probably more of a challenge for us if we don't actually have the time to spend with people. And then think about the adjustments that people need to make to actually living with cardiovascular disease. Because it's not always that straightforward, for sure. If you've got someone with heart failure who takes diuretics, it can actually impact pretty significantly on their life sometimes. Next slide, Gabrielle. So in the United Kingdom, we have a clinical guideline that essentially advocates this stepped care model. So this is now moving into who supports these people. And it's really important that, for people with fairly, we'll see a lot of these people, obviously it's very, very prevalent. But the people who have relatively straightforward, if I can perhaps describe it like that, mental health conditions. So you'll see in steps 1 and in 2 that the assessment is needed for everybody. But beyond that, then it's around essentially understanding what is wrong with people. And it could just be very simply that they need a space to talk and to actually get that support through essentially you just having a chat with them about how things are going and what they could maybe do as an action plan. Beyond that, though, there are some individuals where they have persistent symptoms, and the stepped care model that's here is around depression, but there's others for all of the other mental health conditions. But when you start getting to the more moderate or severe depression states or anxiety, then actually that's much more challenging, because often it's much more complex and multifaceted in why it's happened in the first place. But indeed, the actual intervention that these people need is probably much more specialized. So essentially, the model is for people who have mild to moderate disease or symptoms, then healthcare professionals should be sufficiently trained to be able to support these people. But if the people have more complex disease, or it's much more prolonged, or their whole picture just looks much more challenging to work through, then really the specialism that comes with a psychologist or a psychiatrist is probably needed to then actually provide that support. It's not sufficient just for that lower level, less specialized input. For me, there's something around how do we then appropriately train healthcare professionals. So now in undergrad, I'm an educationalist, and undergraduate programs for nurses and allied health professions and medicine in the UK, we do put in, cognitive behavioral therapy. There's basic talking therapies inherent in the programs now, but we know that people, once they graduate, are not always that confident to be able to do this. And if you have someone with suicidal ideation, how do you cope with that? Because that's not something that I've been educated for, and that is really, really challenging. So you need to know when to refer on, and you also then need to know what the referral pathway would be. We know from the Global Cardiac Rehab Survey from a few years ago now that the number of programs that had psychologists or some sort of psychological input was around half, so not accessible by everybody. But we also know because of that the waiting lists for these specialists are quite lengthy. So it's really trying to manage this as we go through. But I think this needs unpicked a lot more about how do we actually support the people at the coalface, at the actual cardiac rehab programs to do much more of this. Next slide, Gabrielle.
Video off and just have a listen to that.
So just in summary, mental health is obviously a real challenge for us across the globe, and as the pandemic continues in many countries, even although restrictions are easing in some places, I think it has become more problematic. And I certainly think the good thing, if anything, that's come of the pandemic is people are maybe more encouraged to talk about it now, because it is so rife. It is important for us to do the psychological assessment that is comprehensive in nature, it's individualized, and it's holistic. And we should be thinking about that more, what's described as a trauma-based approach that I've not really gone into today. The step care model is important, but for me, there's a gap in how do we recognize when it's not our clinical skills that are needed anymore, it's more specialist skills. And I think that's certainly something that needs a bit more work. But in all of this, we need to establish that therapeutic relationship with patients. And that's a challenge in time, in space, in our feelings of our confidence in doing that. Because sometimes we will unpick things that we really struggle to think about how we would actually encourage and support patients with, encourage patients to deal with. So we need to think really carefully about how we prepare ourselves and our staff and students for undertaking these roles in the future. Thanks very much for your time, and I'll stop there. There's some references from the original presentation there, and I'll happily take any questions either in the chat or at the end, as Robin suggested. Thank you.
Thank you so much, Susan. That was extremely helpful and quite practical. And I do like the way you've emphasized that, in fact, we have had a definite increase in the amount of psychological distress and incident cases of depression that are occurring these days. And I guess, Susan, how would you differentiate, or should you need to differentiate the effects of the cardiac disease from what's happening in the world right now?
Really good point, Robin. And I think it is tricky. So, because you may have people who are lethargic because of the medicines that they take or of the condition that they actually have. So it's really about that establishing that therapeutic relationship with a person and trying to really figure out, is this something new, or is this something that's maybe, is it a consequence of the cardiovascular event, or is it something that's maybe much more long-standing? But it's really difficult, I think, to do that in brief interventions or even in some of the time that we actually spend with people. So I think there's screening tools that are available that can really help to differentiate this. I think, the hospital anxiety and depression scale, the PHQ, there's many tools available there. Use the tools to help support your assessment and take time to do that assessment if you have the luxury of doing that. But yeah, it's not easy for sure.
Okay, thank you so much, Susan. And I'm sure everyone here would be thanking you right now. I'm now going to introduce you to Martin Heine. Dr. Martin Heine is a professor and expert in lifestyle and health at Holland University of Applied Sciences in the Netherlands, and a research team member at the Institute of Sport and Exercise Medicine at Stellenbosch University in South Africa. Welcome, Martin. Thank you.
Thank you. Let me just share my screen. Robin, can you confirm that you can see my screen?
I can. Thank you.
Thank you. Thank you to the ICCPR for the invitation to talk today. Slightly different topic than Susan, more on a health system, global health space. I'm just going to ask you to look at these two photos quickly and think for yourself which one of these pictures illustrates a low resource setting. And if you do that, you'll probably come up with the idea that the left picture, at least for me, is a lower resource environment than the right one, just by looking at these photographs. Interestingly, the left one is taken in the United States, a high-income country, some say the richest country in the world, while the right one is taken in a low to middle income country, being South Africa. In global health research, we've been using low to middle income country as some sort of a classification or some sort of umbrella term to cluster certain studies or certain programs and make inferences about those in relation to sometimes high income countries or between low to middle income countries or lower middle income countries, etc. Luckily, we see that we sort of move away from that a little bit. And also the ICCPR has focused a lot now more on using low resource settings as a term. That's actually where the journey to this article that was published in BMJ Global Health originated when I moved to South Africa and started interacting with Professor Grace around the ICCPR. And it started actually with the article where they reviewed the literature on low resource settings. And then when they operationalized the search that was underlying these recommendations, it was actually focused on low to middle income countries. And to me, those two things are not the same. We have low resource settings in high income countries and high resource settings in low income countries, etc. And the two pictures that I showed earlier illustrate that. So we set out a journey to get a better understanding. So if we talk about low resource settings, what resources are then low? Which resources are we missing? And did a scoping review to sort of unravel that concept. So in our review, we focused on the rehabilitation space, simply because rehabilitation is quite a comprehensive intervention. It generally requires a lot of resources, at least from what we know from high income countries. A multidisciplinary team, a lot of equipment, outcome measures, communication structures between layers of care, etc. So we focused on that sort of field. And then the articles that we were interested in had to refer to their setting as being of low resourced. And our idea was that we were going to analyze then if people use or authors use that term, what resources are actually missing. To do so, we've done a thematic analysis, like you would do for qualitative research of interviews or focus group discussions. You can do the same thing for scientific articles. So we analyzed the included articles using this approach where we both used what they call verbatim. So if someone wrote something, then we use it as a code, or more descriptive, where we as researchers make some inferences about what was written in the articles. And during that process, we sort of used the socio-ecological model to describe the different resource constraints that we identified and use this model to organize our analysis. So we identified 48 articles that referred to their study being done in a low resource setting within the rehabilitation space, of which most were randomized clinical trials and most were pertaining to the entity population. If you look at in which countries these studies were then conducted, we saw that most of them were done in lower middle income countries, then followed by upper middle income, which includes South Africa, lower income, and then 17% was also conducted in high income countries. So that speaks to the same idea that there are low resource settings in high income countries. And what was interesting to see is that particularly the USA often describe their research as being in a low resource setting. So we analyzed those 48 articles and we identified 420 unique little codes that speaks to what resources might be missing or low, and merged those into 63 different categories. So these are these 63 different categories. I'm not going to discuss each of those in detail, but if you want to, there's supplemental information that comes with the publication where you can look at these in more depth. What I am going to discuss is the 9 themes that we were able to identify based on these 63 different categories. I'm not going to discuss them in too much detail. So let me just put them all up also in light of the time. So these are the 9 themes that we identified that speak to the resource constraints that authors refer to when their study has been conducted in a low resource setting. And most of these, if not all of these, apply to all the 5 layers of the socio-ecological model. So if we take financial pressure, for instance, that speaks to the potential financial constraints that a person might experience in, for instance, paying out-of-pocket out-of-pocket expenses to get certain medication or certain treatment. Also out-of-pocket expenses to access certain programs, whether you need to pay the taxi or drive a car, there are costs involved. All the way to the other end where there's limited research funding for high quality research on rehab in lower resource settings, health systems expenditure to unlock rehab for specific patient populations, etc. I think most of the people will think of low resource settings either from a human resource perspective, so there's a lack of trained healthcare providers, or sometimes from the physical resources, so buildings, infrastructure. What we found very interesting is that the influence of beliefs and practices is something that came across a lot. So potential cultural barriers to participate in rehab and how those might vary in, for instance, rural areas versus urban areas. And also the research considerations were interesting. Then you talk about methods to obtain informed consent, having research staff access certain sites. I mean, I worked in South Africa, where we had places where the army had to come in to address gang violence. So these impact the way that research can be done, the quality of research that can be conducted, and therefore also the information that is available to policymakers to use to maybe upskill rehab services or drive certain resources. So what we concluded from our exercise in unraveling low resource settings is that when you look at the resources that are missing, you need to approach that from a holistic frame of mind. And many of these themes are not unidimensional. So it's not like there is or there isn't financial pressure. It's more a spectrum in which there are resource limitations on the one hand and more less on the one hand and more on the other hand, and that many of these resource constraints might be interrelated. Furthermore, it's not just about having resources, it's also about the way they are governed. Especially if you look at task shifting models of rehabilitation, that's one of those ways where you can leverage resources that are there and govern them appropriately so that you can increase access to rehabilitation. Addressing in settings where there are resource constraints or where you feel like rehab is not sufficient, addressing a single resource might most likely not lead to more access to rehab or more quality rehab. Each of these factors or each of these 9 themes should be recognized as equally necessary, yet addressing each one in their own right might be inadequate. So it's about the complex of these themes or resources that drive the access and quality of rehabilitation. There are challenges in saying that we shouldn't use low to middle income country anymore as some sort of construct. There are benefits to it as well. For one, it's much easier to operationalize when you do research, whether something is a low income country or whether it's a low resource setting. The World Bank provides these lists of what is a low income and lower middle income country every year. So that makes it much easier to cluster. But we argue that if you do so, that at least you provide nuance in terms of what resources or what aspects you are particularly interested in that that relate to the setting in which the studies are conducted. And moving forward, what our group hopes to do is that leveraging these categories and validate them potentially in another field and hopefully provide tools that allow for more complex comparison between different settings within the rehabilitation space, and also understand better which resources drive limited or quality rehabilitation, and see if we can identify agents of change that might be more efficient to when there's a rehabilitation need and to address those. Before I finish off, I just want to thank the 3 ladies in this case, the 3 women that actually were instrumental to this article and the work that have been done. Chanel van Zyl was the first author and the key investigator in this. She actually graduated cum laude based on this work, and we had some very good interactions with her examiner, which is the editor of BMJ Global Health, on this. Marlies Badenhorst, who was the qualitative expert in this case, Professor Susanne Hanekom, who was my host at the Stellenbosch University, and who sort of helped along the way and great mentor to me. So thank you, and happy to address any questions now or later on.
Thank you so much, Martin. I must say that you were very convincing to me about low resource settings, and I agree that the income is about the overall population, but within that, and addressing just one aspect like finance to one level of the system is absolutely not going to work. But we'll leave our questions for the end. Thank you, Martin, so that we can continue. Our next speaker is Dr. Simon Nichols. Dr. Nichols is a Senior Research Fellow in the Sport and Physical Activity Research Centre at Sheffield Hallam University in the UK, and he's a past member of the Scientific Committee for the British Association for Cardiovascular Prevention and Rehabilitation. Thanks very much, Simon. I'm not actually having any sound, Gabriella.
Hi everyone, my name's Susan Dawkes. I'm the Head of School for Nursing, Midwifery and Paramedic Practice at Robert Gordon University, and I'm a Professor of Nursing and Cardiovascular Health. At the moment, I'm the current President of BACPR, so the British Association for Cardiovascular Disease Prevention and Rehabilitation. I'm going to share with you a short presentation this morning on technology use in exercise-based cardiac rehab during COVID-19. It was a survey that we conducted. I'm joined today by my colleague, Dr. Simon Nichols. Simon is a Senior Research Fellow at Sheffield Hallam University, and at the time the survey was conducted, Simon was the BACPR Scientific Officer. Next slide, please, Simon. So just to give you an overview of what we will cover today, we're going to give you a little bit of context and background to BACPR, just so that you have that understanding of our association. Simon will then go on and present the survey findings, and I will finish the presentation giving a sense of what we think the future direction would be of cardiovascular disease prevention and rehabilitation. Thanks, Simon. So BACPR, some of you will know this already, but our association was founded in 1993. It's made up of elected council members and other people who are co-opted on for their specialism or for the role that they undertake in the organisation that they work in. We have around 1,000 members. They're from a multitude of different backgrounds, so predominantly nurses, exercise physiologists, exercise professionals, but also all of our allied health professionals and doctors. We support about 300 cardiac rehabilitation programs in the UK. There's various ways that we support our members. So we have education programs. They're both certificated programs, but there's also other education that people can undertake for continuing professional development. We host an annual conference. Our next conference is just coming up in October. And we have webinars throughout the year on various topics. And these are really well attended and seen very well received by the audience. We have a number of publications and have done over the years. The key ones are best practice statements, most recently in relation to COVID, and we also are in the process of updating our standards and core components for cardiovascular disease prevention and rehabilitation. We're really keen to move the research agenda forward, so we are able as an organisation to commission some research that we think is a key priority for this area. And also something that Simon brought in when he was scientific officer is an early career research award. And we also support travel awards for our members. Hopefully that just gives you a flavour of our association, but we're very keen to make sure that we advance cardiac rehab, and particularly the advancement of the prevention and rehabilitation agenda. I'm going to hand over to Simon now to share with you the findings from our survey. Thanks, Simon.
Thanks, Susan. So, hi, everybody. My name is Simon, and I'm going to be talking through the BACPR survey findings of how technology was used during the COVID-19 pandemic. before I move on to discuss that, I think it's just important to briefly highlight the COVID-19 timeline in the UK, because actually it varied country to country, and it does provide important context for some of the information that we provide in the survey results. So the first confirmed COVID case in the UK was on January the 31st, 2020, and the first death from COVID-19 was actually on March 5th. The UK went into a harsh national lockdown March 23rd, where unless you were considered essential or a key worker, you were not allowed to leave the house more than once a day. And when you left the house, it had to be for exercise or groceries. We opened the BACPR survey on the 2nd of June and closed the survey at the end of July 2020. During this time, some changes to our national restrictions occurred, most notably on June 29th, when the national lockdown was replaced with a rolling lockdown, where local communities were locked down hard again, but in response to locally rising cases. So our study findings capture this period in time. The survey was designed as a 35-item questionnaire. It was reviewed by all of the authors and the BACPR Council, who provided feedback. The survey was amended in response to their independent recommendations. As is common these days, the study was designed in conjunction with guidance from the Equator Network, specifically the Cherries checklist, which you'll find attached to the paper, the link to which is at the bottom of this slide. And then the questionnaire was sent to BACPR members, promoted on social media and emailed to our authors' personal contacts between 2nd of June to 31st of July 2020. The key points that the survey explored were if and how cardiac rehabilitation was being delivered during this period of the COVID-19 pandemic, the demographics and medical complexity of patients that were able to access and be treated by cardiac rehab services. And then the key part of this survey was how technology was used to undertake patient assessments and deliver the exercise component of cardiac rehabilitation. We also touched on the barriers that healthcare professionals were encountering when trying to use technology to deliver the exercise component of cardiac rehabilitation. So we received a large number of responses. So for transparency, there were 407 visits to the questionnaire website, but 330 of these progressed to complete responses, which gave an 81% participation rate. The vast majority of responses were actually from the UK, with only 10% of those responses being from outside of the UK. But as you can see, we did capture a number of responses from across the world. The key finding from this survey was that around half of all cardiac rehabilitations were suspended between June and July 2020, and I'm aware that the ICCPR study found similar proportions of cancelled programmes as well. The proportion of programmes that were entirely suspended in the UK was similar to the proportion of programmes that were suspended internationally. As you can see, that the programmes that were most likely to be affected were phase 4 long-term maintenance exercise programmes. I think one of the most interesting findings from this study is demonstrated by this figure here, which shows the rate of technology adoption over time. We asked cardiac rehabilitation services to report when they first started using the technology that they are using now. And the earliest point in time a rehab program reported using technology was 2010. What you can see over the x-axis over time is that the uptake of technology to deliver cardiac rehabilitation remotely is incredibly slow until you reach 2019, where in the UK we had a policy document that was released that aims to increase uptake onto cardiac rehabilitation from the current approximate 50% of eligible patients to 85% of eligible patients. And this sparked a diversification in the way the cardiac rehab was offered, including home-based programs. But again, perhaps not unsurprisingly, the biggest change in the rate of technology adoption happened around the time the World Health Organization declares COVID-19 to be a pandemic. And on this figure here, you see an exponential increase in technology used to deliver cardiac rehabilitation. With the benefit of hindsight, it may be not that surprising, but it's worth noting that for the last 10 years, there has been calls to make better use of home-based cardiac rehabilitation that have largely come unanswered. So this is a really important step, which Susan will come to in a little while. The median date of technology adoption was in fact 30th of March 2020, and only around a fifth of programs were using technology before that date. Perhaps a little underwhelming, but what these figures show here is that technology utilization was generally low tech. This question here is a tick all that apply question, so it may not come as a surprise to viewers that telephone was amongst the most commonly used technology to deliver assessment and deliver the exercise, support the delivery of an exercise program. I think what surprised myself was that postal and paper services were then the next most common for assessments, then email. But live video conferencing much less commonly used in these processes. What these figures obviously don't show is how this might have changed as the pandemic progressed. We had a second and a third lockdown of sorts. So it may be that cardiac rehabilitation services were able to make better use of the rapid influx of technology from different small to medium-sized enterprises and businesses. What was a little concerning is whilst most programs were able to provide physical activity advice, around 4 in 5 programs could do that, only around 60% of programs were able to offer structured exercise training. So there was a large proportion of programs that weren't able to offer anything formal to their patients. So we move on to some of the barriers. This was quite interesting, and I'd like to point out here that this is healthcare professionals' experiences of the barriers that they encounter, and it says what this table tells us is how commonly healthcare professionals are encountering these problems, not how many patients have these problems. First, I'm going to ask you to look at the bottom of the table, which shows that only 2 respondents said that they encountered no barriers to adopting technology, which is probably something we should all be a little bit concerned about in the 21st century. But the most common barriers that healthcare professionals were encountering was a lack of smartphone application devices, tablets, computers, and internet connection. And I suppose somewhat encouragingly, concern about patient safety and patients' safety, concerns about their own safety appear much further down the table. And I personally find the fact that 9 in 10 healthcare professionals believe technology should be used for future program delivery quite reassuring. What they're not saying is that it should replace face-to-face, but it should feature either as a menu of options or as a hybrid approach. So if we just briefly touch on safety, I think in this instance, there's a bit of a conflict in what healthcare professionals are saying and what healthcare professionals are doing, because whilst less than half of healthcare professionals said they were concerned about patient safety with remotely delivered cardiac rehabilitation, only half of programs are actually offering a service to patients at high risk of further cardiovascular event according to the AACVPR guidelines. So I think this is quite concerning. It threatens to introduce a new health inequality as a result of COVID-19. COVID-19's highlighted a number of health inequalities, so we need to do our best to make sure that this doesn't become another one, especially given that there were no reports of life-changing injury or death during this period, and only 3% of programs reported an adverse event resulting in minor injury. So we really need to pay close attention to that. So just to conclude before I hand back over to Susan, half of respondents said that their cardiac rehab service was entirely cancelled during the period of this survey. We need to consider what impact that has had on patients, and if services are still cancelled, as governing bodies, we need to do our best to support them to get back up and running and treating patients. The rapid adoption of technology that we saw during this period of COVID-19 is something to be optimistic about, and there is general appetite within healthcare professionals to retain this as an option, which could help promote wider participation in the future. So thank you very much for listening to that part of the presentation. I'm going to hand over to Susan now, who's going to talk a little bit about the qualitative findings.
Thanks, Simon. So just to give you a flavour and follow on from what Simon said, there was a few qualitative findings that we wanted to share with you because we really felt that it tried to capture the feeling of the staff. So the first one was really around the impact on patient experience. So they felt that by not providing the cardiac rehabilitation programme, that the patients then would have that lack of ability to meet with others, and they'd miss out on that social and emotional support from each other. So doing something in a virtual way was not necessarily something that the healthcare professionals felt would be beneficial to the patients. The second thing that came out was the challenges for staff. So what their main concern was, and we saw this from a number of people across the country, was the concern was that they would not be able to complete some sort of functional capacity assessment of a patient. And that then would probably mean that the patient would be exercising at a lower level than would be desirable. And that really was a challenge that we saw, and certainly BACPR was able to publish some best practice statements and some position statements at that time. And the third one was really implications for the future delivery. So although, as Simon said, the healthcare professionals were really keen to embrace technology beyond the pandemic, they did feel that face-to-face assessment was far superior, really particularly for the frail patients and those that would be at higher risk, their comorbid patients. So there was really a feeling that the technology was useful, but for some people. And I think that's a really key point. Simon, if I could have the next slide, please. So where were we pre-COVID? Dave Thompson, Chantal Ski and Alex Clark described this in a publication in 2019. So this is pre-COVID, that the cardiac rehabilitation landscape, the current scenario was akin to 40 years in the wilderness. And their publication went on very eloquently to say nothing had really changed particularly much, but we knew that half of the patients came, that meant half of the patients didn't attend. The study from Tarkadawi and the team from ICCPR found that there weren't enough cardiac rehabilitation slots for eligible patients. And I know Sherry Grace has shared that with a number of people at different forums across the years. We knew, though, that cardiac rehabilitation, even when it was delivered, wasn't that effective in enhancing outcomes. And we also knew that cardiovascular disease mortality was increasing. So there was many challenges there. And as Simon said, the policy document that was published in the United Kingdom set us really stretching targets where we had to achieve 85% uptake of cardiac rehabilitation in the very near future, which is very difficult to do by not changing particularly much. Simon, next slide, please. So as Plato said, necessity is the mother of invention. Okay, necessity in this case was COVID and the pandemic. And really that was the step change that was needed to get people to think about doing cardiac rehabilitation in a different way. And as you'll see there from the figure that Simon shared earlier on, as he said, the real drive was pandemic came, the lockdown happened, and the healthcare professionals had to think of a different way to do this rather than bring the patients in and do their face-to-face classes. Simon, if I can have the next slide, please. So where are we going? I think obviously technology is key to be a part of that suite of cardiac rehabilitation options for patients. It needs to be menu-based. And it needs to be very much patient-centered. So it's not about us determining what the patient's choice would be. It would be, Simon, could you go back a slide? Thank you. It would be us making sure that the patient was central to that decision-making. It's really important that it's an individualized program. So we need to do an individualized assessment of patients. But then the important thing is beyond that, that the program that they undertake of rehabilitation is still individualized to them. So what's not helpful, it seems, is to do that individualized assessment and then essentially give them that standardized, generic program that everyone would get. Obviously, we need to increase uptake, and we need to really embrace, there's been some fantastic novel options and innovations that have come about because of the pandemic. But there is a need, as Simon pointed out, where healthcare professionals needs to be digitally literate, as well as the patients if they are using technology. So we need to upskill the healthcare professionals so that they in turn will be able to make sure that the patients are supported. It is key though that as we move through, we're still very challenged with COVID in the United Kingdom, but as we move through and hopefully the pandemic subsides worldwide, that we don't just go back to doing what we were doing previously. Simon, if I could have the final slide, please. Simon and I want to just thank all of our co-investigators for the study that we've conducted. And finally, I just want to thank you for listening. I want to thank ICCPR and AACVPR for the invitation to present. And Simon and I are delighted to be able to join with you today. Thank you very much.
Thanks very much to Susan and Simon for that very interesting presentation on COVID and what can happen. I'm a little bit interested. Everyone talks now. There's a lot less talk. It used to be very much our patients aren't ready for digital technologies, but really they are. The great bulk of patients, again, quite willingly, they're using digital technologies and Zoom and FaceTime and WhatsApp, all of those kind of things, WeChat. It's often the health professionals that are needing support to learn the skills to do such things as breakout rooms for social skills. Okay, thanks very much. And I just remind everybody to add questions to the chat, please. The next person, our final speaker, I'd like to introduce now. It's Dr. Maria Rosan Trani, who's the Program Director of the Chonghua Heart Institute Cardiac Rehabilitation Unit in the Philippines. She's a member of the Cardiac Rehabilitation Society of the Philippines, and Gabriella is just getting those slides ready to share now for us. Thank you. Maria, are you fine to go? Maria, you just need to unmute.
Okay, that's it. And
if Gabriella, yeah, thank you. Thanks so much.
okay, thank you. Indeed, this is an enjoyable evening, and I'd like to thank ICCPR for considering us as far as presenting what we have in the Philippines. So I also presented this in Singapore during the SPCRS 2021 Symposium last October. May I have the next slide, please? So I have no disclosures related to this talk. And this is the outline for my presentation. So I'd like to quickly give you a background of the impact of COVID-19 in the Philippines, particularly the healthcare sector, and of course, focus on its effect on the delivery of cardiac rehabilitation during the pandemic. And what we have been trying to do, although it might really be low tech, but I just like to share what we did. Next slide. So it was in March of 2020 when we recorded, the Department of Health recorded our first case of local transmission. And within a week, our president declared our country to be in a state of calamity, at least for the next 6 months. And of course, they created this interagency task force to dictate what they're going to do. And they put this enhanced community quarantine in high-risk areas, mostly the densely populated areas of Metro Manila, that's the capital area, Metro Cebu, and Metro Davao. So what it essentially meant to us was closure of non-essential services, for which, next slide please, it meant as far as rehabilitation was concerned, that we were all put on skeletal workforce. There was, of course, imposition of strict observance of infection prevention and control protocols in place. Next slide. So what has happened, like it was reported in 2020 in one of the ICCPR webinars, our gyms were left, were closed. So it was quite sad for us during that time. Next slide. All the center-based OPD cardiac rehab services were interrupted, but we tried to give phase 1 or deliver phase 1 cardiac rehabilitation to our ACS patients, especially those post-PCI and post-CABG patients who were non-COVID. But the sessions were done at bedside, and the staff were all required to comply with the proper use or hospital policies of the PPEs and, of course, patient interaction. And as such, the Cardiac Rehabilitation Society of the Philippines, as well as the Philippine Heart Association, Council of Cardiac Rehab and Sports Cardiology, put out these consensus statements. So we had to limit enrollment to phase 1 non-COVID patients. And like was presented earlier, necessity actually allowed us to think about delivering cardiac rehabilitation through virtual means. But of course, we had to haggle with the hospital administration regarding this endeavor. And there was resumption of face-to-face sessions only upon the IATF quarantine status in a certain location, and of course, upon approval of the hospital administration, as well as the control of infection service, so that there was less face-to-face sessions during that time, and more, we were trying to go for or looking forward to more virtual sessions. Next slide, please. And due to the help of the different webinars and those that you have shared with us, we tried to use this as a means of coming out with our own local consensus statements. Next slide, please. So we met these different challenges. We do know that, of course, this was related to the disease. So when it first came out, some of our colleagues, especially in the National Capital Region, cardiologists, actually succumbed to the disease when they took care of ACS patients who actually had COVID. So a lot of them got hit. And so we had really a scare that time, and of course for the hospital staff as well. And of course we had challenges with the institution, with the hospital admin on how we can go back to work, because they felt that we were not a priority. Our staff were transferred to other units, and of course the skeletal work schedule, which was really a problem then. And then in the Philippines, when we had these lockdowns, so it was incumbent upon the hospital admin to provide transportation and lodging provisions for our staff. And as to the proposed infection control setup, this also added more burden on our on the hospital because of the things, the barriers that they had to set up, procure PPEs and the like. No, so it really gave the hospital people or the admin a hard time. Next slide, please. And of course, the other challenges were patient-related. They had the fear of coming to the hospital and access to transportation, and our seniors were really mandated to stay at home. So since our patients were mostly seniors, so they could not really have no access to coming out of their homes. And then, of course, the challenge of how to modify the delivery of cardiac rehab. As said earlier, we ourselves, the cardiac rehab specialists, are really not adept yet on how to provide or go about delivering tele-rehabilitation. And I had to convince our hospital administration as to why it was advantageous, especially to our patients, to provide cardiac rehabilitation despite the pandemic. And of course, training of our staff. But then, next slide, innovation really forces us to make changes, to be proactive, And it was at that time that we had to fast track and really try to learn how to deliver virtual care. And very fortunately, through our resources here in ICCPR, we were able to get hold of these guidelines, especially from the Canadian Association of Cardiac Rehab. Next slide, please. So we took a look into our own local papers available, like the one published by Dr. Leochico, a colleague, the challenges of the emergence of tele-rehab, and we really attributed the challenges and were related to internet access. We then really discovered that access here in our country is poor. And then second, it was related to legal issues. There were no legal policies in place as to the practice of tele-rehab until the pandemic. And then lastly, skepticism itself from the healthcare providers, because they're not really sure how this would actually help our patients. But again, through we went through the different webinars and review available data and the CACPR toolkit, as well as the AACVPR guidelines, and this beautiful paper from Sir Scherenberg. So this helped us really push forward and try to get the help of the admin people to start some form of tele-rehabilitation in our institution and in other institutions in our country. Next slide, please. So at this time, we have about 17 center-based cardiac rehabilitation units. Majority are located in the National Capital Region and Central Luzon. About 4 centers here in the Visayas, particularly in Cebu, where I practice, and about 2 centers down south in Mindanao. We predominantly give face-to-face sessions, but about 5 of the 17 centers have started virtual cardiac rehab in one form or another. Next slide, please. So these are the institutions where I work with: Chonghua Hospital and Perpetual Socorro Hospital. Next slide, please. And currently we have reopened, but as we said, it's a limited number of patients. We have to do social distancing. We have now opened and included our phase 2 cardiac rehabilitations, and our other centers in Manila have actually opened phase 3 and 4. But we do abide by strict hospital rules or protocols, and it's mandatory to fill up all those health declaration forms. And our rehab units are now equipped with HEPA filters, disinfection after each use, social distancing, no strict hand washing, and the like. And we now accept post-COVID patients, provided they have been cleared to start their rehabilitation from their ID, infectious disease specialist, or from the PULMA service, and of course from the Hospital Control of Infection Service. Next slide, please. So what we did, we coordinated with the hospital administration, medical director, how we are going to do this new delivery model. We had to coordinate with our people from IT, and also convince the people from the prevention and control of infection services, the legal staff, because we had to revise our consent forms to allow our patients to join us in video conferencing. And then we had to have some training for our staff, and of course go over the checklist that tells us how we should conduct a VCR. And then of course educate our patients and their significant others as to what they will be expecting. So what we did, next slide please. Informed consent was obtained from all those patients desiring to continue their cardiac rehabilitation in their homes. Inform these patients what they expect, but we only allow initial intake and assessment to be done at the hospital. And for home-based cardiac rehabilitation, we provided them with supervised exercise sessions and the links to which the education can be done. So what core components we delivered? The supervised exercise sessions to video conferencing, educational opportunities one-on-one during their exercises, and of course provided that the links that have been made available to us by our friends from ICCPR. And of course we conducted our own lay forum through webinars through Facebook. So most of them right now we deliver video consultation through the messenger application. Some have smartphone applications, but right now our hospital is really looking into what we call the patient portal, where our patients can access this site and really be secure their privacy. So this was initially how we did it. We were given just one computer wherein we do the video conferencing, and then we had to use some smartphones as the patients. There were also more patients, and we could only do one at a time. And eventually at this point in time, we now have an additional computer setup for the virtual monitoring. And then of course this is the checklist that we have at the side of our healthcare provider, which we got from the CACPR toolkit. And when they go home, of course we tell them, our patients, that they must have their BP apparatus, their pulse oximeter, an ordinary pedal foot exerciser, and of course be familiar with the Borg scale, as we will be asking them at the end of each session how they rate their exercise session. This is the data that we got from, so we closed March, April, May, and started some face-to-face sessions in June. So the ones in red, slowly, there were VCR sessions. And January, February, March of last year, we had again a surge. So the VCRs would go up, but then as the surge goes down, then the face-to-face sessions become more. And it was only after June of 2021, next slide, that some people already tried to join us in hybrid. But if the numbers are improved or low, like what we had during December of 2021, then all our patients decided to come and see us and do face-to-face sessions. But even at this point, our patients still do have, or we still provide the VCR sessions for them. So we were able to see 75 patients all throughout from June of 2020 until December of 2021. 67% have completed their programs. Currently, they are still finishing their programs, but a big number have not completed the program, primarily because in December, when we got hit by a very big storm, we lost all signal. And so this we had to forego delivering the cardiac rehabilitation sessions. And it was only until early of March that some of them we've been trying to contact them, but most of our patients are already back to work or cannot be accessed or cannot be reached. So next slide. So these were the reasons why our patients did not complete. So most of them were signal problems, and one expired, but fortunately not during VCR. We lost touch, but when we got hold of them, the relative informed us that our patient expired. This was an elderly heart failure patient who was supposed to be due for intervention but was not able to make it. So next slide. So our observations at our hospital, definitely an overall reduction in the number of referrals. Although most of our patients still prefer the coming in face-to-face, well, I think this would be because of the improvement in the vaccination efforts. Although we still had about 5% to half trying to still join us through virtual means. But despite this, we still really had more dropouts in the face-to-face sessions dictated by the surges in pandemic. We did not have very negative events reported during the actual rehab sessions. So as to the adherence rate, would this be acceptable? About a 67 to 70% adherence to the program. And of course, we're still going about doing surveys on how to assess whether they were satisfied with this new mode of delivery, and of course, assessing the quality of the remote delivery of our core components. So on that paper, these were some of the advantages that we really saw: greater privacy, we avoided the transportation barriers, protection from the virus infection. But of course, our action points are still going about the lack of legal principles, going through the data safety and privacy, and more importantly, digital literacy is a problem in this part of the world. Next slide, please. So we are in for the long haul. We are now in step 3, trying to develop and sustain these innovative solutions, trying to find ways with the IT park, with the IT function, and trying to educate our patients on how to go it, because we really plan to continue delivering virtual cardiac rehabilitation even after the pandemic is over. So where do we go from here? We'd like to participate in all your efforts, because we also want to standardize our efforts and collaborate with you guys, and bringing about trying to assess the effectiveness of virtual care versus center-based cardiac rehabilitation. So that is where we're going in the future: strengthen alternative models, and of course, locally also investigate the effect of virtual cardiac rehabilitation on these different parameters: recurrent events, rehospitalization, mortality data. So with that, I'd like to say that definitely being proactive, being resilient, and adapting to the times is key. And we keep on learning. We thank you for these kinds of learning opportunities. And then we also get to know, or rather we realize the importance of getting support from our hospital administration and other key functions in the hospital, and especially our friends here in ICCPR. And of course, we really hope to continuously reassess and improve our local programs. I think that's the last slide. Thank you.
Thank you so much, Maria. I'm encouraging everybody to look at the chat where we have a whole list of questions and answers from some of our speakers already. We have kind of gone to the full extent of our time, which is unfortunate, because I'm sure everyone would have loved to have asked questions of our speakers. I would like you to remind you that of our scholarships that are available, 20 scholarships for the ICCPR Cardiovascular Rehabilitation Foundation certification, which is due on May 29. And please go to our website to find out more. It's likely that many of you would have liked to have asked a question of our speakers in detail, but I'm very conscious that we have gone over time and I wouldn't like to use up people's work time. But if you would very much like to ask a question of our speaker, I encourage you to contact Gabriella by replying to our Gabriella Gissi and through our ICCPR website. And we guarantee that we will follow up those questions and ask those of our speakers. But I would right now like to thank Professor Susan Dawkes, Dr. Martin Heine, Dr. Simon Nichols, and Dr. Maria Trani so much for their very informative work. Thank you so much. And Gabriella, over to you. Anything from you?
I just want to say thank you so much for everyone. And I just type the email if you have any questions.
Okay. This session has been recorded and it will be put onto our ICCPR website as well.